Finding Hope, the Road to Recovery.
Hello, I'm Dr. Ken Bachrach, Clinical Director of Tarzana Treatment Centers, and I'm joined today by Dr. Clifford Feldman, who is the Psychiatric Medical Director of Tarzana Treatment Centers. We're going to be talking today about the use of psychiatric medications in the treatment of patients who have both psychiatric and addiction or substance use disorders. This is something that we see a great deal at Tarzana Treatment Centers, and we wanted to give you a little insight as to the role of the psychiatrist and psychiatric treatment. So Dr. Feldman, thanks for joining us today.
It's a pleasure, Dr. Bachrach.
Could you tell us a little bit about your background and your experience?
Sure. Well, it depends how far back you want to go. I'm from New York, and I got my undergraduate degree at Cornell University, went on to law school at Syracuse University College of Law, then progressed to medical school in Chicago, and I did a psychiatric residency where I was chief resident at NYU Bellevue in New York City. And that's when I moved out here and started my private practice. And I've been at Tarzana as the medical director for about 2 years. And as you know, I worked at Tarzana for several years, about 10 years ago.
Well, thank you very much. Could you tell us a little bit about the types of patients or what patients you see during your work at Tarzana Treatment Centers?
Absolutely. We see a wide variety of patients, and sometimes it's very complicated because we see patients who not only have a psychiatric illness, but also have substance use disorder. And sometimes when they have both and they're co-occurring illnesses, it's very hard to tease them out. We see people who have major depression, bipolar disorder, schizophrenia, schizoaffective disorder. We also see people who are coming into detox from opioids, getting off of meth, stopping using alcohol, and sometimes they have both. So those are the types of cases we see frequently at Tarzana.
Well, you mentioned a number of things. I'd like to go back and kind of unpack it a little bit, if you don't mind. In particular, you mentioned depression. So what is depression? I think people know you get sad and stuff like that, but how is depression different than just getting like sad once in a while?
That's a good question. You know, people do get sad once in a while, and it's not considered something that's treatable or pathological. If someone dies, grief and mourning is considered a normal reaction, and it's nothing to be treated. However, if people who are functioning well become sad for a prolonged period of time to the point where it impacts their ability to function, they cannot sleep, they cannot eat, they're losing weight, they're anxious, they may have suicidal thoughts, that's when it's time to seek help.
Well, I know there's been a lot of attention to suicide and how much of a problem it is. So when you have a suicidal patient or a family member, you know, I know one of the things they mentioned that you should always do is don't try to ignore it, but to talk to the patients or to the family member about it and ask them genuinely, do you feel suicidal? Do you feel like hurting yourself or taking your life? And be willing to hear their answer. And if they say they feel like they maybe want to hurt themselves or they can't see living, then you really need to seek professional help, because this is a big issue that we want everybody to identify someone who may be severely depressed and suicidal. Now, you also mentioned other types of disorders. One of the ones you mentioned was bipolar disorder, which is often where there's mood fluctuations, some very severe and some maybe not so severe. Can you talk to us a little bit about what bipolar is and how might someone even identify it in a family member or a friend?
So bipolar disorder, or what's often called manic depression, is characterized by at least one episode of mania. So you can have depression a bunch of times, but if you have mania once, then you have bipolar disorder. If you have what's called hypomania once, which is a little less mania, and I'll describe what mania is in a second, then you may have what's called bipolar 2 disorder, or even cyclothymia. But a manic episode is when someone who's not using any kind of speed or sedatives has rapid thoughts, pressured speech, you can't get a word in edgewise, they can't sleep, they do erratic things, They may be getting to spending problems or travel capriciously with no destination planned. Those kinds of things are the hallmark of mania, and that's bipolar disorder.
Now, when people have bipolar disorder, are they only manic or have mania, or do they also then have depression too?
Yes, they have to have depression, but to get the diagnosis, you need at least one manic episode. You can have depression, major depression, 5 times. But if you have one manic episode, then you're diagnosed as bipolar. Now, why is that important? What's the difference if you're bipolar depressed or depressed and not bipolar? It does make a difference in the treatment. For instance, if you give someone an antidepressant with major depression, you just watch them recover to baseline. But if you give that same dose of antidepressant to a bipolar patient who's depressed, you might overdo it and they might become unstable and go into mania. So you have to be careful. So the diagnosis makes a difference in the treatment.
Well, thank you. Now, another thing you mentioned were more of the psychotic disorders. What is typical of a psychotic disorder, and what are some of the ones that maybe people know the names of?
Well, I think the most common when you think of psychotic or losing touch with reality, the thing that people most likely think of is schizophrenia. Okay, so people know that young people, maybe like 15 to 25, are susceptible sometimes to getting psychosis, which is hallucinations or delusions or things like that. But there's a lot of other people who get psychotic. They can get psychotic from major depression with psychosis and hear voices that tell them they're bad people, etc. You can get psychotic from using methamphetamine or other drugs that, cause you to hallucinate and act erratically. So those are the most common ones. I would say schizophrenia, people know. Drug-induced is very common, unfortunately, and mania have psychosis.
So how has the care of patients changed over the years that you have been in practice?
It used to be that someone who's using drugs would have to get clean first before the psychiatrist would treat them for many reasons, and one is a med-legal reason. Another reason is that all these medications are tested on people who are not using drugs. So yes, that was the old school. And in my opinion, the new school is that we can't wait for you to get clean. We have to start treating you now because you may be self-medicating. And if we could treat your psychiatric illness, hopefully that will relieve you of the need to go out and buy methamphetamine. For instance, if you have attention deficit disorder and you're self-medicating with methamphetamine, you're going to the dealer or whatever, you're putting yourself at risk. If you're treated for it, you may not have to go to the street or get arrested or do things to get illegal substances.
Now, I know in the past there used to be what I would call almost sequential care, meaning that someone who came in for psychiatric care, if they were using substances, they said, oh, we're not going to treat you. You got to get clean first. You got to stop your substance use. Similarly, it used to be that people went in for substance use who also had psychiatric needs. They would say, oh, no, you need to first care for your psychiatric stuff, and then we'll treat your substance use. So how have things changed since that time?
Well, I think some of that still happens to a degree, but at Tarzana Treatment Center, we have a comprehensive multidisciplinary team where we all work together to help the patient, and we don't pass the buck. Both things are treated simultaneously, especially in the inpatient unit. We have all the doctors see the patients, the psychologists and everyone. So it's not sequential, it's at the same time.
Right. So this kind of integrated care model is one of the things that I think has developed over the years and that's really important for everyone to understand. If you're dealing with a loved one who has an addiction and also a possible psychiatric issue, you need someone who can treat both of those at the same time, not just one or the other at different times. And the other thing is that even if you have both treated, you need to have communication. And that's one of the things at Tarzana Treatment Centers we are very proud of doing, is that we have one team that talks to each other, that provides that integrated care. which is often really the state of the art now in terms of treatment for both mental health and psychiatric disorders. Now, you were mentioning some drugs or substances, and one of the things you mentioned were opioids. And I know that there's a huge opioid epidemic today in our country and I think around the world. Could you talk to us about what an opioid is and what are some of the different types of opioids that people use?
So opioids are generally painkillers, like prescription heavy-duty painkillers. And maybe you've heard of OxyContin or Oxys on the street, or Vicodin, even fentanyl, which is used in anesthesia, and even other things. But on the street, it's Vicodin, it's fentanyl, heroin, of course, are the major opioids that we see opioids of abuse.
And I think it's important to point out that while some are prescription medications like OxyContin, hydrocodone, or Vicodin, and others, there's also heroin, which is not a prescription drug. It is something that people use illegally, but they all have the same effect, right? They're all opioids. And so if someone's taking a pill versus taking heroin, is there really a difference in how they feel or what it does to them?
Well, that's a multifactorial question because the answer is when you buy stuff on the street, you don't know what's in it. And some people die because they don't know fentanyl is in their usual dose and they overdose and they didn't intend to because it was laced with fentanyl. Some of these things come from other countries and who knows what they cut into it. So it's hard to know what you're taking.
That's an excellent point. And one of the things that we're really dealing with right now around the world is the increased supply and use of fentanyl that is being not only put into heroin, but even like methamphetamine and even pills that look like they're manufactured, but they're really illicitly made. So the reason why fentanyl is so dangerous is about 50 times stronger than heroin, and you can easily overdose, and it happens extremely quickly. So that's one of the things why we really are trying to educate people about the use of what's called Narcan, which the generic name is naloxone, because if someone can give you that Narcan or naloxone right when you overdose, it can save your life. But if you wait 5 minutes or longer, sometimes it's even too late for that.
In New York, they're giving Narcan in dispensers on the street. So yes, that could save people's lives for sure.
So what is the goal of prescribing medications to patients at Tarzana Treatment Center who have both an addiction or substance use disorder and a psychiatric disorder?
Well, the goal of prescribing meds at Tarzana Treatment Center is no different from the goal of prescribing meds anywhere else that a psychiatrist does or a detox doctor. The ultimate goal is to get the patient to function. Okay, but how do they get to function if they have a psychiatric illness and chemical dependency? So oftentimes they have to be detoxed. Not all drugs need to be detoxed, but certain ones do, like opioids, alcohol. You can't just stop taking those. The withdrawal is terrible. It could be life-threatening in the case of alcohol. So sometimes you have to clean up, and then perhaps if the patient is self-medicating with those things, you have to understand what's going on with them and what symptoms they have to medicate them. Now, we've been talking a lot about medications, but the treatment isn't just medications, it's therapy too. These patients have a lot of trauma illnesses, there's a lot of PTSD that goes undiagnosed, that patients bury and then they just use to cover up the feelings. So our treatment includes that. Group therapy, individual therapy, trauma therapy, all those things. It's not just about medication.
So could you tell us a little bit about the role that psychiatric medications play in the treatment?
So for instance, people with depression who don't have bipolar disorder will be evaluated for antidepressant medication. What are those? Prozac, Zoloft, Paxil, Cymbalta, Effexor, maybe you've heard of those. So we The patient undergoes a full evaluation by a psychological team to see if they're bipolar or see what issues they have, what symptoms they have, and what diagnoses they've been given in the past, in addition to what substances they were using before they walked in. So for major depression, it's pretty simple. It's antidepressants. If you have bipolar disorder or an unstable mood, you may not need antidepressant. Even if you're depressed, you may just need what's called a mood stabilizer. And these include lithium, Depakote, Lamictal are some common ones used to stabilize the mood. You don't want to kick someone from depression to mania by just giving them an antidepressant. They may just need a mood stabilizer. Someone who comes in with psychosis, whether or not it's from drugs, it doesn't matter. Once you have psychosis, you treat it with antipsychotic medication, Haldol, Risperdal, Zoloft, Abilify. There's a lot of them. Those are the major meds we use, because that's a lot of the people we see with the diagnosis like that. One more thing, if we have schizophrenic patients, we may consider long-acting injectable antipsychotic. And what that is, patient can get an injection and the medication is in them at steady state as if they were taking a daily pill for 1 month, 3 months, or even 6 months, depending on what injection you give.
And I think that's a very valuable improvement in terms of treating patients with these severe psychiatric disorders, because I think everybody knows it's hard enough to take a pill every day, and if you have a serious psychiatric condition, they may forget it, they may be unstable, they may not even be able to manage their meds. So if you are getting an injection either once every month or every few months, that means that the medication is on board and you're getting the effects and the treatment from the medication. And that's a very valuable thing for people with those severe psychiatric conditions. I think many people are not aware of that. That's kind of something that's happened more recently, and it is something that is very beneficial for those patients.
And our patients have been receiving that at Tarzana Treatment Center.
So when someone comes to see you and you have to determine both their condition and maybe what medication you're going to start them on, how do you go about doing that? I think it would be important for everyone listening to understand the process, because I think it's somewhat of a mystery, that you go see a psychiatrist and they give you some medication, but talk about, really what happens so that people can understand when you go see a psychiatrist, what occurs and what can they expect?
So what occurs on the inpatient unit is similar to what occurs in the outpatient when you go to see someone for the first time. We take a thorough history to understand what symptoms you have now, what symptoms you've had in the past. Have you been hospitalized? Have you taken meds before? Well, which ones were good? Which ones were bad? What medications have people in your family taken that were beneficial? We review the records to see what other people have said about your condition in the past, if you do bring them. You get a medical checkup often, so to make sure there's no medical etiology to your psychiatric complaints. And then we have to make a decision. The decision is not just the doctor's, because the patient has to take it. So we decide what medication we think will help your symptoms. Then the patient has to decide, I want to take that or I don't want to take that. But then the insurer has to decide, I want to pay for that or I don't want to pay for that. So sometimes it's tricky to get all those things to turn green and light up.
Now, I understand with psychiatric medications, which is different than most other medications, patients have to sign a consent. Can you tell us what the consent is and what it's for?
In many places, there's a requirement that the psychiatric patient sign a consent for psychiatric medication, whereas they don't have to sign any consent for non-psychiatric medication. So it is a little odd in that sense. It's to make sure that you have informed consent. We don't want the notion that psychiatrists are giving people medication against their will, like maybe in the 1800s. We want you to know what you're taking, and you should know what you're taking. I want you to Google what you're taking. I want you to look it up. Yeah, I'm going to tell you the common side effects, but I want you to look it up. I want you to know. And then I want you to sign that you did that to prove it in case something happens later.
So part of it is to talk about the side effects as well as maybe go over the benefits too of taking the medication. And I think one of the things, that you do in that consent is hopefully then the person is agreeing and you're getting their buy-in to take the medication. So after they've signed the consent and maybe they've agreed to taking the medication, the next thing that we probably have to talk about is what happens after someone is started on a medication. Because obviously I know sometimes there have to be like adjustments, there have to be changes in medications, and how do you figure out, basically what that person needs. We'll be back in a few minutes with Finding Hope, Road to Recovery with Dr. Cliff Feldman. So stay tuned. Welcome back to Finding Hope, Road to Recovery. I'm Dr. Ken Bachrach, and I'm here with Dr. Clifford Feldman. And before the break, we were talking about medications and how you figure out once someone is started on a medication, what happens? I mean, do you change the medications? How do you figure out, if an adjustment is needed? Could you please explain that to the viewers?
Yes. So there's inpatient medication where you're literally hospitalized and seen every day. And the pace of things in the inpatient is much more rapid, changing meds, seeing patients every day, as opposed to the outpatient where oftentimes you're seen once a month. So let's say on the inpatient unit, someone comes in hearing voices and things like that, and they're started on medication. They can start feeling better very soon. First of all, if they're agitated, the medications calm them immediately. The voices to stop may take a day or two. For depression, getting a good night's sleep might help initially with some medication, but antidepressants sometimes can take a couple of days to work. But just getting sleep and being in a structured environment on the inpatient unit, going to groups and having therapy sessions will help you, having a structured day, recover quickly on the inpatient unit. On the outpatient unit, like I said, you're most often seen monthly. However, if you started on a new medication, I usually don't like to wait a month with someone on a new medication. So I'll have you come back in 2 weeks. And at 2 weeks, we will assess several things. Number one, did you take the medication? Because sometimes the patient will be like, Doc, I feel great, feel awesome. Did you take the medication? No, I did not. So you want to see if they're taking it. Then you want to see how they feel. Do they feel better? Do they feel worse? And then you want to see if they have side effects. Those are the biggies.
And what kind of side effects do you kind of run into, or what should patients expect to know that it is possibly a side effect?
So it depends on the type of medication, the side effects. The antipsychotics mostly produce sedation, but they could also produce what's called Parkinsonian symptoms. That includes a face with no expression. It includes a tremor, rigid muscles, etc. So we really need to watch for that on antipsychotic medication. Antidepressants in the old days had more side effects than in the new days. So in the old days, with what's called tricyclic antidepressants like Elavil or Pamelor or Tofranil, people got dry mouth, constipation, urinary retention, blurry vision, and things like that. The advent of the SSRIs, or the new generation antidepressant, so many millions and millions of people have taken them because the side effects are relatively nil. With Prozac, and maybe some diarrhea. You may get some sedation with Paxil, but generally they're well tolerated and have very few side effects, which is why they're so popular.
Now, you had mentioned that on the inpatient unit, if you're depressed, you take an antidepressant, you might feel better in a couple of days. But isn't it true that sometimes antidepressants can take much longer to be effective? It can take weeks. Because I've heard very often one of the things is that people stop taking their antidepressants too soon before you know whether it's working or not. Can you talk a little bit about that?
Yes, well, on the inpatient unit, it's the same as being an outpatient in terms of when the medication is going to really kick in. But on the inpatient unit, you have an entire team of people caring for you. You're getting, if you're on drugs from the outside, so you're not using now, so that stuff is getting out of your system. You're probably eating more regularly. You have group therapy. You have ancillary services. Aside from the fact that you've let yourself get treated, once you go in for treatment, you've kind of stopped resisting and you're just letting yourself be treated. And there's a lot to be said for that in terms of the course of your recovery. If the court sends you to Tarzana Treatment Center, your prognosis is not as good as if you voluntarily go in there because you want to be clean and feel well. So yes, technically the antidepressants could take 6 to 8 weeks to fully kick in, but they can kick in early after a few days. But these other things are what help people get better in a few days. Now, the length of stay at Tarzana is not 2 days. It's probably somewhere around a week. So we do wait to see if you have any side effects or if the beneficial effects of the medications or any side effects, things like that.
Now, we also have outpatient programs at Tarzana Treatment Center. So if you were treated like with an antidepressant as an outpatient and then sent home, what would you tell the patient to expect?
I would say, depending on the medication, if you have any side effects, call us right away. You don't have to wait for your next appointment. There's always someone to call. There's always a number, etc. Some antidepressants can cause people to feel worse sometimes. So yeah, absolutely. If you feel worse or if you have side effects, call right away. But what I would tell them to expect is you should feel better. Within a week, you should start feeling something from the medication. And it could take 6 to 8 weeks. Now, do we start people on the therapeutic dose all the time? We don't. Because some people, if they have any side effects, they'll immediately stop. So for instance, Prozac therapeutic dose is 20 to 60 milligrams for depression. There's some patients you might start on 10 because you know if they get a side effect, they're done. So those people, you say, try this. I want to see if you have any side effects, and we might have to titrate or change the dose, increase the dose, sometimes lower the dose. And those people, you kind of have to really be gentle and start very low so they come back and go, doc, and no side effects whatsoever. Okay, you also were not on therapeutic dose. Now we're going to get you to 20.
So I think that's an important point that you raised, in that sometimes you're started on a low dose and you may not get the desired effects, but you shouldn't really stop taking your medication. You should probably go back to your doctor and say, hey, it's not really working for me. And then the doctor can maybe adjust the dose. Similarly, if you're having side effects, there may be things that they could do too, either adjust the dose or maybe try another antidepressant. So how do you go about choosing the right, let's say, because we're talking about depression here, there's many antidepressants on the market. Again, you don't need to go into extreme detail, but if you could tell the viewers, how do you go about in terms of your thought processes, in terms of trying one medication versus another? Is it something in terms of the symptoms the patient is presenting? And, if you could just explain that a little bit, that might be very useful for people to know.
Yes, so that is the million-dollar question that the pharmaceutical companies would like to know so they can pitch their wares to doctors so they know how you make these decisions. But it's actually a decision that has many, many points to it, but we can make in a few seconds. It's unbelievable. So first of all, the thing we look at is, what are your symptoms? And what do we want to treat? So I say to the patient, okay, they have every symptom. I say, what, number one, pick one. That's the first. We look at the symptoms because each of these medications has side effects. So if someone has trouble sleeping, you might pick a more sedating one. If someone has trouble with their energy level, you might pick a more activating one. So that's a consideration. What have you taken in the past that's helped? Okay, we're going to probably try that again. What has your mom taken that helped? We might try that. What is your insurance going to cover? You might be limited to a certain formulary. What are you requesting to take? Some people come in and go, I want, Lexapro, things like that. So all these things guide my hand when I'm deciding what to give a particular patient.
Now, you mentioned one thing that about you would ask, what did your mom take? Why do you ask that question?
Some of these illnesses are partially genetic, and if a family member has a similar diagnosis and had a good response, especially first-degree family, it's not an unusual thing to offer that to the patient. Now, it may not work as well, but that's probably going to be your first line.
So there's really a genetic component, but there may be other components too, environmental, stress, and just the unique makeup of that individual, histories of trauma, things like that, that all could impact that. So you now have somebody on a medication. They maybe are starting to feel better. Do they just stop? Could you tell us a little bit about the life cycle of someone who has a serious mental illness and the role of medications? And I mean, is it something they need to stay on for life? And if so, why?
So a lot of people take medication, they feel better, and then they want to stop. And a lot of times that's okay if it's supervised. What I tell the patient is if you stop, the likelihood of do you remember that relapse you had, 6 months ago? The likelihood of you having
When you say relapse, could you explain what you mean by that?
let's say someone was first put on medication for a crisis 6 or 12 months ago. They were put on antidepressant because they were suicidal or they were hospitalized. So now it's 6 months, a year later. And they're like, I feel great. I want off these meds. You say, okay, you're a free agent. You can do what you want. But do you remember when you were hospitalized? Okay, the chance of that happening goes up markedly if you stop these medications. The chance of you having a relapse is not zero on the medication, but it's less. So we're playing percentages. So some people might choose to be on a lower dose for a longer period of time. Some people might want to see what it's like to be off medication. There's nothing wrong with that. And some people just choose to take it because it's inexpensive and they have no side effects and they don't want to be like that again. They don't want to be hospitalized again.
So it sounds like it's almost a risk-benefit kind of decision that is made with the patient and the psychiatric provider. And you kind of work as a partnership to kind of come up with what the patient wants to do, even though realistically it's always the patient's decision, but you're giving them some guidance. And for some patients, they may say it's not worth the risk. Others may say, I don't like being always on a medication, so I'm going to try it, but still maybe be supervised by the psychiatric provider so that if something changes, like they notice start getting sad or depressed or something like that, they can resume the medication.
Yes, wanting to be off medication, there's nothing wrong with that. A lot of people think psychiatrists are pill pushers and they want that they get some kind of benefit from you being on meds. If you don't want to be on meds, that's fine with me. But I just have to tell you, the chances of you relapsing go up.
And that's one thing I know that at Tarzana Treatment Center we struggle with some patients on, is that patients want to be off the medication, but they may not always even recognize all the symptoms that reemerge, even though friends and family members may see that. And so that's why it's important that maybe when they stop medications, that you bring in their family too, so that to say, if you notice these symptoms again, you need to bring them back because you may notice it before they do, because they may not be as aware as friends and family around them. Now, we have other kind of chronic diseases like diabetes, asthma, hypertension. Are these psychiatric illnesses, are they chronic diseases similar to those medical kinds of diseases?
I think that's a good way to conceptualize them to the patient. If you say, look, they're like, I don't want to take this. I don't want to be crazy all my life. I don't want to take these pills. You say, this is like high blood pressure or diabetes where you don't take some magic pill as of yet and you're cured. It's a thing you manage. So we manage symptoms. Sometimes people on medication plateau. They take the antidepressant and they're fine at this dose. They plateau and maybe they start slipping. Maybe they need an increase in dose. But if you plateau, you might need a change in medication. So it's a constant readjusting. Like the doctor who just refills your medication by phone every month for a year, you're not really getting treatment with someone doing that.
So that's an important point, meaning that your medication needs may change over time. And that while a certain dose of a medication may work for a while and you may feel totally normal and feel good, over time the effectiveness of that medication may wane, and therefore you may either need an increase in the dose, or do you sometimes even need to change medications?
Yes, you can swap or add.
So that's why you need to often stay in touch with your psychiatric provider, similar to a primary care provider. If you have diabetes or hypertension, you may have to be monitored for years. Now, the aim is that you're stable and you're able to live a normal life. But there may be times where, either due to stress or the medication's not working as well, that you may have to have some adjustment in those medications. We've been talking a lot about this kind of in the abstract. Can you think of like a patient that you've treated that you could maybe talk about to kind of give some, sense of how this actually works in the real world?
So we have had many treatment successes. We've had some failures. Treatment is a two-way street. It's not the doctor imposing treatment on the patient. The patient has to want to accept treatment and come for treatment, most likely voluntarily. So yes, one particular case was a woman who met with me for the first time, and we clashed, and I think she might have been using at the time. She had bipolar disorder. She was using methamphetamine, marijuana, alcohol. So the first time we met, she was asking me for like addictive medications like Xanax and things like that, and I said no. And so she got up and she left the office, and I thought that was the end. But a couple of months later, she came back, she apologized, and she accepted treatment. And to make a long story short, over time, she was able to not only get her children back, but she's clean and attending university.
Wow.
So that is a treatment success. When you first get together and it's like that, and you're like, whoa, you're not ready.
So how long a period of time was it from the time you first saw her to the time she was, attending university and doing really well?
I think it was like 18 months.
18 months. So that's not a quick fix, so to speak.
But that's a long distance she traveled.
So this is someone who really started off with great needs, and then through the treatment of you, and who else was treating her too besides you?
Yes, so she had a treatment team. She had a case manager to help her get housed. She had a therapist who she saw every week for therapy. So yes, it was a full team.
So, it's kind of like mind, body, and spirit kind of thing, that you have to treat the whole person. And here, there was an integrated care team at Tarzana Treatment Centers where Dr. Feldman provided the psychiatric care. A case manager helped her with some of her kind of real life needs like housing and things like that, maybe even enrolling in school. And then the therapist helped with some of the emotional needs too, because medications don't really fix how you relate to other people, how you deal with stress, how you handle conflict. It basically gets you to a point where hopefully you can begin to do that and think things through and kind of recognize maybe what you need to do to move forward. So that, I think, is very, very important to realize that it can take months, it can take years to make this kind of improvement. Now, this is obviously a great success story that you're talking about, but I'm sure there's some variations, that not everyone has this straight line, that there's sometimes ups and downs, and some of it may be due to life situations, some of it may be due to maybe medications not working as well, patients stopping taking medications, other things that are developing in the person's life. We talked a little bit about about the inpatient treatment in the hospital, But could you talk a little bit about what we often refer to as levels of care? What is there besides being in the hospital or inpatient treatment?
So the highest level of care actually is involuntary hospitalization, where you're put in there against your will. At Tarzana Treatment, we have voluntary inpatient care. So that's also a very high level of care, treating people with psychosis, suicidal thoughts, those kind of things. Now, just shy of that, the next lower level of care is like something like a day program or intensive outpatient program, where people are coming in for treatment 3 days a week. So that's pretty intense. It's not every day like inpatient, but it's 3 days a week. And we offer that, as well as outpatient care, where you're seeing the therapist maybe weekly and seeing the psychiatrist maybe monthly. So those, as you progress and get better, you need lower level of care.
I think that's an important point to recognize. And I think one of the things at Tarzana Treatment Centers we offer is we offer that full continuum of care. And so it's not like we're saying, oh, you have to go into the hospital or you have to go into this program. We assess where you need to go based on an evaluation and saying, you don't need to go in the hospital. You just need to start an outpatient care. We'll hook you up with a therapist, a psychiatrist, maybe even a case manager if necessary, and we'll work with you that way. But one of the things, too, that you did mention is that you do need to want treatment, right?
In most cases, yes. We do have some people who are referred by the court and remanded for treatment. And if they don't get treatment, they go to jail. So we do get those, but that's in the minority. You really have to, even if the court remands you and you don't really want to have treatment, it's not going to work. You really have to seek treatment and want help. And the help is available if you want it.
Well, I really appreciate you talking all about the different medications, the kind of course of treatment, as well as what's involved with determining even level of care in terms of what you need. Is there a message that you want to leave our audience with today regarding psychiatric treatment and medications?
Since the pandemic, these things have been a little more open in the press and celebrities talking about their problems. And if I have to leave a message, it would be that if you feel you have some of these problems, that help is available, and oftentimes at no cost to you. If you feel depressed, if you're using drugs, you have to want to get help. And if you do, the help is there. That's my message.
Yeah, and I think that, just to remember that while medication is one part of treatment, it's not all of treatment, and that's where therapy comes in, family support, all of those things play a role. And most importantly, I think the message I'd like to leave our audience is that there is hope. There are competent professionals who can provide you or your family members with the care that you need. You do not have to suffer alone. It is still a stigma very often around the world that if you have a mental health problem, you're labeled as crazy or something. But there is effective treatment. And so please understand that there is hope, there is treatment, and that's why we are calling this whole segment, Finding Hope, the Road to Recovery. So I'd like to thank Dr. Feldman, and I'm Dr. Ken Bachrach. Thank you for joining us today on this segment of Finding Hope, the Road to Recovery.
Brought to you by Tarzana Treatment Centers. You can visit our website at www.tarzanatc.org or call 1-800-996-1051.